You can start.
Okay. Good evening, participants. Thank you for joining today for the webinar on our page Shield Connect. And today we have a speaker from Mumbai, Dr. Vaishali Killekar, and Madam is going to take a session on resistant vaginal infection. So before we go for the webinar, let me give a little idea about our Shield Connect page. So let me share the screen. So this is our page shieldconnect.in. You can log in and you can see various sections available on our platform. So when you click on blog, you will able to find various blog related to mucormycosis, COVID-19 and other topics related to PCOS and other topics related to male infertility and female infertility and menopause. It is written by various eminent speakers and doctors. Then we have another section, webinar section, where you can find upcoming webinars. You can find all the calendar showing all the webinars which are available for this month. So when you click on see more, you will able to register, and then you can find this page. And in the comment section, you can post your queries and your feedback. So at the end of the session, we can have an interactive Q&A session with our speaker for the day. Then there is a past webinar page. So you can find all the past webinars which were done on the Shield Connect page. Then we have awareness pages. There are 3 awareness pages. So first is the immune booster page, where we have relaunched Rhodamine Mu. So you can find all the details related to respiratory immunity. Then there is a PCOS awareness page where you can find various doctors speaking related to PCOS topic in various languages like Tamil, Hindi, Malayalam, English, Hindi. Then recently we have updated one more new page, COVID-19 awareness page. So you can find all the blogs and videos related to COVID in this page. Then we have a special section. So like days related page, like a hypertension day. So you will find all the videos related to hypertension day. So this is our page Shield Connect. And let me give a little intro of our speaker for the day, Dr. Vaishali Killekar. So ma'am is MBBS, DGO, DNB in obstetric and gynecology. Ma'am is infertility specialist in Gandhi Nursing Home in Borivali, Mumbai. So, ma'am, I welcome you on our platform.
Yeah, thank you so much for calling me.
So, ma'am, should I start sharing the slides?
Yeah, please share the screen.
Okay, ma'am.
So today, should I start?
Is it visible, ma'am?
Yes.
Yes, sir. Yes, ma'am. You can start.
Okay. So today we are going to speak about resistant vaginal infections. Now, to brief first about the normal vaginal flora. Next slide, please. So as we are aware that there are many different kinds of bacteria which inhabit the vagina, like lactobacillus or bifidobacterium. And the main role of these natural bacteria is that they excrete hydrogen peroxide, which maintains an acidic or a low pH environment. This definitely acts as a natural disinfectant, and it also maintains the normal balance of the organisms in the vagina, which is hostile to disease bacteria. Now, any condition that changes the vaginal acidity or disturbs the normal bacteria in the vagina, they can predispose to an infection. Normally, there is a very delicate balance between the two major microorganisms, which is found in the vagina of the woman during the reproductive years. And these microorganisms commonly are the Candida albicans, which is a type of yeast or fungus, and Lactobacillus species, which is the bacteria. Now, in a normal ecosystem in the vagina, next slide, please. The three important factors remain that the estrogen, which is secreted during the reproductive years, this maintains the thickness of the vaginal wall. So, during the reproductive years, since the thickness is very much is more thicker, so that is why the infections do not normally penetrate very fast. And the vagina pH in the vagina is maintained between 3.5 to 4, as we already discussed by these useful bacteria like lactobacillus as well as bifidobacterium, and so they maintain an acidogenic environment. Now, as we can see here, that glycogen, when the lactobacilli, these particularly act on the glycogen in the vaginal cells and they produce increased lactic acid. This maintains a pH of less between a 3.8 to 4.5, and this promotes further growth of the lactobacillus, therefore more hydrogen peroxide production, and in turn it inhibits the pathogenic bacteria to flourish. Now, coming to the next slide. So when we talk about vaginitis, which is one of the most common gynecological condition which is encountered in our OPDs, it is mainly defined as the spectrum of condition which causes vulvovaginal symptoms. Now, the most common symptoms which any patient which would present in an OPD are itching in the vagina or on the vulva, burning sensation, or irritation post intercourse, or abnormal discharge. Now, the most common causes of vaginitis are bacterial vaginosis, which constitute up to 40 to 45% of the reason. Vulvovaginal candidiasis constitute 20 to 25%, and trichomoniasis, they are responsible for 15 to 20% of the vaginitis. Next slide, please. Okay, so the other differential diagnosis when we look at other than these three would be vulval dermatitis, which could be allergic or irritant, genital herpes, which is now getting much more common, bacterial vaginosis, as we discussed, lichen sclerosis, urinary tract infection, and vestibulitis. Next slide, please. So when we look at the risk factors of increased vaginal infection, any person who has a very poor personal hygiene is prone to vaginal infections. Obesity, the reason being is when the body fat index increases, the thigh fat particularly increases as well. So because of that, the aviation is not there, which is a normal mechanism. And that is also responsible for vaginal infections. So also wearing clothes that are too tight, they also act in a similar way. The other reasons being using too much of soap or uncontrolled diabetes, which is one of the major reasons. And even after giving treatment, we may not get a desired result that we need. So that is one of the most important reasons. So uncontrolled diabetes or even pre-diabetes for that matter. Now that we are seeing many patients, so those also come up with vaginal infections or also recurrent vaginal infections. Now, use of feminine deodorants, douches, and scented sanitary products, they could act as an irritant in some patients, but it is a person-specific reason. That is, if a person has some particular is if she's too sensitive or she has an allergic component, then definitely it could be the predisposing factor for an additional vaginal infection. Excessive use of antibiotics and hormonal contraceptives, they could be the cause of like decrease in like decrease in all the bacteria which are present. So even the good bacteria as well as the bad bacteria both are decreased. So in turn, they can later cause a predisposition to fungal infections. Stress, change in sexual partners, and unprotected sex with someone who has a particular STD. pregnancy, recent childbirth, or menopause. Now, these three factors particularly decrease the immunity for a certain period post pregnancy or menopause. After that, the general mechanisms, that is, the estrogen level decreases. Also, the pH might falter. So, these are the time that vaginal infections are much more common. Inadequate sleep and stress are go hand in hand, and poor nutrition. So poor nutrition, particularly if will predispose to decreased immunity, and they will be like a welcome factor for all these opportunistic infections which can present as vaginal infection. Next slide, please. Now, for the recurrence of vaginal infections, there have been many theories which have been put forth. Now, the first being the intestinal reservoir theory. This suggests that persistence of the organism in the gastrointestinal tract later can reinfect the vagina. The second theory being the sexual transmission theory, in which it is believed that the sexual partner could be the reservoir or the source for the recurrent infection in the woman. So, if we do not take care of that factor, then definitely the patient is bound to get reinfected as soon as she starts keeping relations again, which is an unprotected relation. The third factor being the vaginal relapse theory, which states that even with treatment, some women will remain colonized with the organism. So in this case, it could be in patients with poor nutrition or with a very much like type A personality or with too much of stress in their life. So in these patients, since the immunity is not that great, some or the other infection is just not getting treated, and that is why that forms the base for recurrence in the future. Next slide, please. So when we're talking about recurrent or chronic vulvovaginitis, this is definitely frustrating to the patients as well as it is a burden to the healthcare system as well. And it can be infectious as well as non-infectious in etiology. It is most often underdiagnosed or misdiagnosed, because in India particularly, women are very shy to come up with any of their problems related to the reproductive system. So only when it increases to a certain level that now they cannot manage it, that is the time that they come forward. So we normally tend to cater to these patients at a very end stage, that is, they are really suffering badly, and that is the time that we are actually addressing them. The three types of infectious vulvovaginitis, which is most commonly seen in the reproductive age women, are bacterial vaginosis, vulvovaginal candidiasis, and trichomoniasis. Other differential diagnoses, as we have already reiterated, are herpes simplex infection, allergic reaction to irritants, and non-infectious vaginitis like lichen planus, genitourinary syndrome of the menopause, and desquamative inflammatory vaginitis. Uh, this infection, as well as inflammation of the vulva and the vagina, it can be associated with itching, burning, irritation, dyspareunia. Dyspareunia means pain while keeping intercourse, and abnormal and or malodorous vaginal discharge or foul smelling discharge. So coming to the next slide. Uh, Now to come into the details of these different types of infection. Now, if we take the most common three infections, that is the bacterial vaginosis, yeast infection, and trichomoniasis. So, in bacterial vaginosis, there is a overgrowth of the bacteria which is naturally found in the vagina. And in yeast infection, it is particularly an overgrowth of the fungus in the vagina and or at the vaginal opening. In trichomoniasis, it is particularly caused by a parasite. If we talk about the odor, bacterial vaginosis infection has a particular peculiar fishy or an unpleasant smell, and yeast infection normally does not smell so much, or it doesn't have a foul odor, and trichomoniasis infection has an unpleasant smell. So but the most peculiar or a clinical diagnosis can be, if the fishy smell is there, then bacterial vaginosis can be diagnosed any which ways. Now, coming to the discharge, in bacterial vaginosis, it is a thin, milky white or gray discharge, whereas in yeast infection, it is thick, white, cottage cheese-like discharge. And in trichomoniasis, it is particularly frothy with yellowish or greenish in color. So it can be, so that is the reason that if some patient calls you up and tells you, can you do a online consultation, it is always better to tell them that for first consultation, please come to the clinic so that we can actually see the primary infection and diagnose it properly, so that you do not end up into recurrences if we give over the counter or online consultation. Now, coming to the next point, being itching, burning, and irritation. Yes, it is present sometime, but it is more common in yeast infection, and also it may be present in trichomoniasis. Now, coming to the increased pH, in trichomoniasis and bacterial vaginosis, in both of them, the pH is increased, but in yeast infection, it is not particularly increased so much. Next slide, please. Now, taking it one at a time. So, coming to bacterial vaginosis. Bacterial vaginosis is a polymicrobial clinical syndrome resulting from replacement of the normal hydrogen peroxide producing lactobacillus species in the vagina with high concentrations of anaerobic bacteria. So, vaginal discharge. But most of the women with bacterial vaginosis were asymptomatic. Now, next slide, please. When we talk about bacterial vaginosis associated via sexual activity, it is associated with patients having multiple male or female partners, a new sex partner, douching, and lack of condom use or lack of vaginal lactobacilli. Women who have never been sexually active are rarely affected. Now, the cause of microbial alteration that precipitates bacterial vaginosis is not fully understood, and whether bacterial vaginosis results from acquisition of a single sexually transmitted pathogen is not really known. Nonetheless, women with bacterial vaginosis are at increased risk for the acquisition of some sexually transmitted diseases, such as HIV, Neisseria gonorrhea, Chlamydia trachomatis, HSV2. So these complications after gynecological surgery, complications in the pregnancy, and recurrence of the bacterial vaginosis. They also increase the risk of HIV transmission to male sex partners. Although bacterial vaginosis associated bacteria can be found in the male genitalia, treatment of the male sex partners has not been beneficial in preventing the recurrence of bacterial vaginosis. Next slide, please. When we come to the diagnostic considerations, the clinical criteria of AMSEL and or the gram stain is much more important. In this, a gram stain is considered the gold standard laboratory method for diagnosing the bacterial vaginosis, and it is used to determine the relative concentration of lactobacilli, that is the long gram positive rods, gram negative, and gram variable rods and cocci. Like for Gardnerella vaginalis, as we said, Prevotella, Mobilincus. So these are the characteristic. In Mobilincus, we'll be seeing curved gram negative rods. Now, the clinical criteria requires 3 of the following symptoms or the sign. In this, the first being homogeneous thin white discharge that smoothly coats the vaginal wall, or there could be presence of clue cells. This is absolute diagnostic test. If these are diagnosed, then it is a clinching factor. So in this, vaginal epithelial cells which are studied with adherent cocobacilli on microscopic examination, then the pH of the vaginal fluid being more than 4.5, and a fishy odor of vaginal discharge before or after addition of 10% KOH, that is potassium hydroxide. This is the whiff test. And detection of three of these criteria has been correlated with the results by gram stain. Then we can definitely conclude that it is a bacterial vaginosis infection. Now, other tests like FMVP3 or the DNA hybridization probe test, these are the specialized tests which are now available for the diagnosis of the bacterial vaginosis. This detects the vaginal fluid sialidase activity and have acceptable performance characteristics compared to the gram stain. Cervical pap smear, which is normally done, has no clinical utility for the diagnosis of bacterial vaginosis because of their low sensitivity and specificity. Next slide, please. So what do you mean by recurrent bacterial vaginosis? Recurrent bacterial vaginosis is defined as 3 or more episodes in 12 months. Recurrence rate is high and often involves frequent telephone calls and visits to the clinic. Multiple treatments are prescribed in the absence of a curative therapy. Now, Bradshaw et al. Reported recurrence rates of around 58% over a 12-month period in women treated with oral metronidazole for 7 days. In the study, recurrence was associated with prior history of bacterial vaginosis, lack of hormonal contraceptive use, and having the same sex partner throughout the study duration, and having female sex partners. Now, the repetition rates as high as 30 to 50% within 3 months is designated as recurrent bacterial vaginosis. Other factors that have been associated with the recurrence include douching, frequent sexual intercourse without condoms, failure to re-establish a lactobacillus predominant vaginal flora, and it has also been suggested that formation of a vaginal biofilm in bacterial vaginosis could be one of the important factors for this recurrence. Now coming to its treatment, next slide please. There have been many recommended as well as alternative regimens containing an anaerobic cover. So, particularly metronidazole, tinidazole have been orally as well as intravaginally. Clindamycin can be used. So, a few being metronidazole 500 milligram orally twice a day for 7 days, or tinidazole 2 gram orally once daily for 2 days, or clindamycin ovules 100 milligram intravaginally once at bedtime for 3 days. So all these are effective regimens against the bacterial vaginosis. Now, clindamycin ovules use an oleaginous base that might weaken the latex or rubber products, that is the condom or the vaginal contraceptive diaphragms. So if you're using such products within 72 hours following treatment with clindamycin ovules, then it is not recommended. Next slide, please. Okay, so when we talk about pregnancy and bacterial vaginosis, nowadays it is recommended according to the newer guidelines to do a vaginal smear in the first trimester or a pap smear as well. So this detects any kind of vaginal infections which may be harboring there. So presence of bacterial vaginosis in the first trimester, they can lead to late second trimester miscarriages and a preterm labor. So this point is very important, and especially with the women with previous history of second trimester loss or a preterm delivery should be examined for bacterial vaginosis, and this should be part of the diagnostic protocol. Metronidazole is safe in pregnancy, but definitely in the second trimester, and we should avoid giving very large doses. Recurrent vulvovaginal candidiasis, next slide. So coming to candidiasis, when we speak about recurrent cases, it affects up to 5% of the premenopausal women, and it is often associated with significant morbidity and may be difficult to manage. Now, recurrent vulvovaginal candidiasis is defined as 4 or more proven episodes of vulvovaginal candidiasis in a 12-month period. Classically, vulvovaginal candidiasis is described as consisting of a white cottage cheese discharge with associated vulval and vaginal inflammation. This inflammation can present as vulval pruritus, a burning sensation, and or dysuria. Burning sensation and dysuria are the more predominant symptoms that the patients present with. In a typical infection, signs include vulval edema, excoriations, and fissures. Women can present with one or all these symptoms. Alternately, women can test positive for Candida, example on a routine pap test with no clinical evidence of infection. So asymptomatic carriage is present in more than 20% of the healthy women. Next slide, please. So when we talk about epidemiology and etiology, approximately 75% of the women will experience at least one episode of vulvovaginal candidiasis, and up to 5% of these women will have recurrent infections, meeting the definition of the recurrent vulvovaginal candidiasis. The incidence of vulvovaginal candidiasis is highest in women aged 20 to 40 years, that is in the reproductive age group. It is rare in the prepubertal and postmenopausal women. Higher estrogen levels are thought to make women more susceptible to vulvovaginal candidiasis. This is seen with an increased incidence in pregnant women and postmenopausal women on hormone therapy. So, a study showed that while women on the combined oral contraceptive were no more likely than controls to have vulvovaginal candidiasis, women on high dose estrogen oral contraceptives have higher rates of candida colonization. So estrogen increases the glycogen content of the vagina and it has a direct effect on candida growth, and it also increases its adherence to the vaginal epithelium. Vulvovaginal candidiasis is often caused by Candida albicans. Candida glabrata is the most reported non-albicans species. Next slide, please. So causes and risk factors of yeast infection being excessive usage of antibiotics, then patient on oral contraceptive on a long course, steroid treatment long course given, pregnancy, diabetes, uncontrolled that too, patient on chemotherapy or conditions or medications that weaken the immune system. So particularly yeast infection being an opportunistic infection, the immunity plays an important role to keep it under check. Next slide, please. So going into the details of the risk factors for recurrent vaginal candidiasis, the yeast factors being increased virulence in the form of ability to adhere to the vaginal epithelium and remain at place for a longer time. Protease production by the Candida species increasing its invasiveness and increased adherence because of the germ tube formation. Now, the host factors, as we just reiterated, that is impaired glucose tolerance or diabetes mellitus, broad spectrum antibiotics given for a longer time, contraceptive pills, and pregnancy, increasing the estrogen content of the body, use of spermicidal jelly, uh, decreasing the normal bacterial flora, steroid therapy, immunodeficiency, and mechanical irritation. So these being the host factors. Now, skin conditions which are most of the time misdiagnosed as recurrent vaginal candidiasis are irritant contact dermatitis or the vulval vestibulitis, bacterial vaginosis, genital herpes, physiological discharge, tinea cruris, psoriasis, or lichen planus. Now, all these can be actually distinguished by a very detailed history. So, the main thing is what is the major complaint between the presenting part. If it is the foul smell, then definitely it could be more of a bacterial vaginosis than a recurrent candidiasis. If there are small ulcers which are seen, superficial ulcers which are seen at the vulva, then it could be more of a genital herpes. Physiological discharge, as we know that it is much more common in the middle of the cycle, that is around the ovulation period, but it is never associated with too much of itching. So we have to be very much concerned with the what kind of symptoms is the patient presenting with. Psoriasis and lichen planus, definitely we will have to go into the details of the cell. So a smear will help us take it further. And irritant contact dermatitis, the history of usage of any new any new chemicals for that area for hygiene purpose, or changing the pad brand or any such thing will give us an idea of the irritant contact dermatitis. Next slide, please. Now, coming to the treatment for vulvovaginal candidiasis, it can many molecules can be used, like polines being a topical nystatin, or azoles like imidazoles, which is commonly used, like topical clotrimazole, topical miconazole, oral ketoconazole, oral fluconazole. Now the recent most fenticonazole. So all these molecules are in place. Also, the other being boric acid intravaginal capsules and flucytosine, which can be used topically. Now, Nishant, yeah, I can see the slide. Sorry. So, uncomplicated vulvovaginal candidiasis is defined as sporadic vaginitis caused by strains of Candida albicans, which is responsive to all types of antifungal therapy. Topical imidazole creams occasionally cause local side effects such as vaginal burning or irritation. Fluconazole is an oral treatment available over the counter and is taken as a single statin dose. Nausea and vomiting are infrequent side effects. Topical hydrocortisone cream can also be used as an addition for symptomatic relief of the vulval symptoms. Next slide, please. So when we are looking at a case of vulvovaginal candidiasis, and we are sure that we have ruled out the differential diagnosis, that is the skin conditions which can be misdiagnosed, but it is just not responsive to our standard treatment, then it is important to go ahead with the culture. Now, if the culture is positive for Candida albicans and it meets the definition of recurrent vulvovaginal candidiasis, that the patient has had more than 3 culture proven episodes in previous 12 months, then a longer duration of treatment is recommended. That is, either you double the course of intravaginal pessaries, or the fluconazole 150 milligram per day can be used for 2 days, or ketoconazole 200 milligram per day can be used for 10 days. We have to also commence a suppressive treatment, that is intravaginally we can give clotrimazole 500 milligram weekly, or a fluconazole 150 milligram oral weekly dose, or a ketoconazole 200 milligram oral daily dose. This can be continued right up to 6 months to make sure that the adhesiveness of this Candida albicans is taken care of. Now, in case if the culture is positive for a non-Candida albicans species like Candida glabrata, then we can consider requesting the sensitivity for the culture. Now, in case of Candida glabrata, generally we avoid short course therapy and fluconazole as the first line treatment. But in resistant Candida glabrata cases, boric acid pessaries and flucytosine have been shown to be effective. Next slide, please. Now we are dealing with this new problem of drug resistance. So an increasing incidence of non-albican vulvovaginal candidiasis and a correspondingly high incidence of drug resistance has been debated in the literature. Increased use and maybe possible misuse of over-the-counter antimycotics is cited as the concern. It is proposed that frequent short courses of therapy may eliminate the more sensitive Candida albicans, selecting for more azole-resistant non-albicans Candida species. So this is much more common if the patient has visited you for one episode of Candida albicans infection, and then the patient, whenever she's getting a recurrence, she's self-treating herself with only a single dose of the intravaginal pessary or only a single dose of the tablet, and she's like, now I'm feeling fine, so she stopped the treatment. So that is the time that we can come up with all these problems. However, the evidence for these theories is inconclusive. Now, coming to the studies, there was a retrospective United Kingdom review which was found that in HIV negative women, there was no change in the proportion of vulvovaginal candidiasis cases being attributed to non-Candida albicans species over the 6-year period between 1993 and 1998. Another study done by Sobel et al., published in 1995, found that in 182 fluconazole treated patients, there was 94% clinical response rate. Also, a more recent Belgian study found 21% of yeast isolates were resistant to fluconazole with in vitro testing. However, when they retested 8 samples, they were all very well susceptible to fluconazole. Next slide, please. So coming to the complications during pregnancy due to vulvovaginal candidiasis, uh, there is a risk of miscarriage or preterm birth because of the continuous infection being there and the inflammation. There could be preterm rupture of membranes, low birth weight, and post-abortion endometritis. Next slide, please. So therefore, it is extremely important that the diagnosis of vulvovaginal candidiasis is accurate and accurate diagnosis is necessary.
Ma'am, we cannot hear you. Ma'am?
Vaginitis, which is one of the three most common infections that we are dealing with. Next slide, please. So in this, the recommended regimen again stand or anaerobic cover. So in this, metronidazole 2 gram orally can be given in a single dose, or tinidazole 2 gram orally in a single dose. This has shown to give a good cure rate of around 90 to 95%. But in resistant cases, oral metronidazole may be repeated up to 4 to 6 weeks. Also, an alternative regimen can be metronidazole of 500 mg orally twice a day for 7 days in patients who are prone to too much of acidity. Now, next slide, please. Follow-up is the most important. Next slide. Follow-up is the most important factor, and it is now. But in patients who have become asymptomatic, it is not particularly necessary for men and women to undergo follow-up, but who are symptomatic definitely, or they are not sure of what this is. It a physiological discharge or is it something which is again restarting? Then definitely we should go ahead with the follow. Now, management of sex partners. Sex partners of patients with Trichomonas vaginalis should be treated, and patients should be instructed to avoid sex until they and their sex partners are completely cured. So, a dual management is necessary. In special considerations, when we look at pregnancy, vaginal trichomoniasis has been associated with adverse pregnancy outcomes like premature rupture of membranes, preterm delivery, and low birth weight. However, data do not suggest that metronidazole therapy results in reduction in the perinatal morbidity. So, women may be treated with 2 grams of metronidazole in a single dose, and metronidazole is a pregnancy category B drug. That is, the animal studies have revealed no evidence of harm to the fetus, but no adequate, well-controlled studies among the pregnant women have been conducted. So should be used judiciously. Next slide, please. In recurrent trichomoniasis, in women who fail the 2 gram metronidazole without evidence of reinfection, metronidazole 500 milligram orally twice daily for 7 days is recommended. If the treatment fails, tinidazole or metronidazole 2 gram orally for 5 days is then recommended. If persistent infection is documented despite the previous therapy without evidence of reinfection, there are case series and reports documenting the success using high-dose tinidazole and compounded paromomycin in management of refractory trichomoniasis as follows. So in this, there are 3 types of regimen in which one we can use tinidazole 500 milligram orally 4 times daily for 1 week, or tinidazole 500 milligram orally 4 times daily plus tinidazole 500 milligram vaginally twice daily for 14 days, or tinazole 1 gram orally three times a day, plus 5 gram of compounded 5% intravaginal paromomycin nightly for 14 days can be given. Next slide, please. Now, coming to the current treatment options for bacterial vaginosis, antibiotics and antifungal remain the mainstay of therapy, and the recurrence rate is high and is associated with side effects. So, when we look at the future now, probiotics containing lactobacillus, uh, used over a long period and as an alternative to the antibiotics, particularly within the context of high infection recurrence rates. So there is a possibility of harnessing specific bacterial strains in order to prime the vaginal microbiota in the pre and peri-conceptual periods. So coming to probiotics, now what are probiotics? Probiotics are live microorganisms which when administered in adequate amounts confer a health benefit on the host. The main types of microbes being lactic acid bacteria and bifidobacteria. They are commonly found in fermented foods. Live cultures are usually added and yogurt, dietary supplements, they are a good source. Coming to prebiotics, prebiotics are compounds in food that induce the growth or activity of beneficial microorganisms. That is, prebiotics and probiotics are together called as symbiotics. Now, how do the prebiotics work? Now, in this, the prebiotics improve the work of the digestive system. They stimulate the growth and the reproduction of only useful microflora. They maintain an optimal pH in the intestine. Therefore, they stimulate the local immunity. They remove the excess mucus from the walls of the small intestine and therefore they reduce the formation of gases. They suppress the reproduction in the intestines of pathogenic bacteria and they also stimulate the peristalsis. So next slide, please. So as we can see, there is intestinal microbiota and there is a vaginal microbiota which is present, and the competition and cooperation between the nutrients and so antimicrobial compound production, competitive exclusion, all of these are factors, and also the metabolic interaction, barrier function, anti-apoptosis, and induction of mucins. Then the regulation of cytokine expression, modulation of phagocytosis, modulation of IDC maturation, and modulation of T cell differentiation being the major mechanism of action. Next slide, please. So, what are the major characteristics of potential probiotics? When we look at them, we are looking at it being of human origin. Then it is acid and bile. It has acid and bile stability. Then it produces antimicrobial substances. It has a good adherence to the human intestinal cells, and also it persists in the human intestinal tract for a longer time. It is clinically validated and documented. It has a documented health effect. Then it has an antagonism against the enteric pathogens. It is susceptible to antibiotics, and it has a safety in food and clinical usage. Next slide, please. The restriction of these probiotics has particularly been said to be in patients with bacteremia or patients with inflammatory bowel
Ma'am, you're on mute. Ma'am, please unmute. You're on mute.
Next slide, please.
Ma'am, it was on mute for few time on this slide.
On this slide, okay, sorry.
Yes, ma'am. Yeah.
Yeah, so we'll go ahead with the restriction of the uses. Now, when we talk about probiotics, we should be giving it with good by looking at the patient profile carefully, that is in patients with bacteremia or patients having adverse immunological effects, or in patients with antibiotic resistance transfer. So in these patients, it should be, the concern is there could be an antibiotic resistance which is transferred in the form of plasmid and lactic acid bacteria. So this has to be more carefully dealt with. Also, patients with prior prolonged hospitalization or prior surgical interventions or diagnosed with immunosuppression. So in these patients also, we should be giving it with care. Next slide, please. Okay, so use of probiotics is generally safe, but these patients should be monitored while using probiotics. As we already said, patients who are immunocompromised, premature infants, patients suffering from short bowel syndrome, and those with central venous catheters, and elderly or patients with cardiac valve disease. Next slide, please. Now, why would we prefer probiotics for infection treatment? Now, the new problems created by the antibiotics being the disruption of the protective flora. So for that reason, probiotics gives a good assistance of treatment. Also, antibiotic resistance due to the abuse or overuse of antibiotic prescriptions and running out of antibiotics, or in the interest in the usage of ecological methods instead. So very frankly, as we all know that all our body is very dynamic and we are able to take care of all kinds of minor infections ourselves if we have a good immunity and we are taking good care of our body. Only in cases when our immunity falters or we are going through tough times and we are really uh, taking care of an overload of any kind of infection, that is the time that the mechanisms, the natural mechanisms fail, and we have to really resort on to visiting a doctor or taking too many antibiotics. So we should also allow the body to recover well and let its natural mechanisms also have a lead into the treatment protocol. Next slide, please. Vaginal probiotic. Next slide, please. Vaginal probiotics, and in this there is a clear hypothesis about the role of lactobacilli. There is clearly established protective role of the lactobacilli, and lactobacilli are predominant in the vagina, and the application can be topical, reaching a high inocular, and it is easy to perform clinical trials like easy sampling, easy isolation of probiotic lactobacilli after application, and it is already available. Next slide. So coming to the rationale of probiotic using lactobacilli, it develops a non-chemotherapeutic probiotic therapy using lactobacilli to maintain healthy lactobacilli dominated vaginal flora. It is more useful in sexually transmitted diseases. It prevents preterm labor. It gives a good quality of life to the woman. It can be inserted directly into the vagina. The oral preparation acts from the gut by transmigration to the vagina, and it is used in women prone to urogenital infections. It can also be given during infection, but also for the healthy woman to maintain the normal flora. Next slide, please. So in women prone to urogenital infections or during infection, it can be given. And also in healthy women as a prophylaxis to maintain the normal flora. And also lactobacilli probiotics can be used over a long period without adverse effects, unlike the antibiotics. So when we speak about probiotic versus antibiotics, antibiotics damage the commensal microflora, and they can increase the occurrence of resistant bacteria, and they can have adverse side effects. Whereas probiotics can be used in adjunction to the antibiotics to restore the commensal microflora. Now, when we speak about an ideal treatment, what would be the requirement? Now, we would definitely, when we are speaking about the recurrent vulvovaginal infections, we would prefer to have an Indian genome specific strain and also a vaginal specific strains to be given to the patient with a maximum colony forming unit of 10 billion CFU. Now, coming to some studies in this Indian medical journal, which was in November 2014. The topic being the biological control of vaginosis to improve the reproductive health. It has been shown that exogenous strains of lactobacilli have been suggested as a means of re-establishing a normal, healthy vaginal flora. Carefully selected probiotic strains can eliminate the bacterial vaginosis and also exert an antiviral effect, therefore reducing the viral load and preventing fetal and neonatal infection. The administration of beneficial microorganisms in the form of probiotics can aid the recovery from infection and restore and maintain the flora. So this is a very important point, and this we definitely use it also in patients in which we are going to give any reproductive treatments like IUI or test tube baby treatments. So in that also we prefer to pre-treat the patient with these. Next slide, please. Yeah, so this study reiterates the same. Abnormal vaginal microbiota may be associated with poor reproductive outcomes. This was a prospective study done on the IVF patients by T. Har, and this was in February 23, 2016. And the summary was that the vaginal microbiota of IVF patients can be characterized with qPCR test, which may be a promising tool for diagnosing abnormal vaginal microbiota and for prediction of clinical pregnancy in IVF treatment. So, in this, only 9% with qPCR defined abnormal vaginal microbiota obtained a clinical pregnancy. So, in the Indian scenario, we would say that since we do not have access to such expensive tests, then definitely it is beneficial to try using these probiotics as a pre-treatment. Next slide, please. Now, why strains of the native origin? When we speak about products with strains of Western origin, they may not have the same benefit to our patients. It is now widely accepted that native strains will have better efficacy on the local population. Also, products should have the advantage that all the strains are of native origin with clinical study and safety validated in the Indian populations in establishing the efficacy. Next slide, please. Now, various lactobacilli have been identified by tDNA PCR, and very important ones being the species being Lactobacillus crispatus, which is also part of a natural defense mechanism. The other being Lactobacillus jensenii, Lactobacillus gasseri, and Lactobacillus iners. As we can see that the hydrogen peroxide formation is much more in these, and Lactobacillus vaginalis and the Lactobacillus reuteri and fermentum, they also have a good efficacy as far as the hydrogen peroxide formation is seen. Next slide, please. So, according to the European Journal of Obstetrics and Gynecology and Reproductive Biology, in this it is shown that when we treat the patient with bacterial vaginosis, it definitely increases the pregnancy rate by around so as we can see these two groups in which the bacterial vaginosis was not treated, the pregnancy rate was very low as only 24%. But in patients in the group in which it was treated, the pregnancy rate was as high as 49%. Next slide, please. So now these are the studies done with different types of probiotic strains for the treatment of bacterial vaginosis. Now, as we can see, in 1992, Hallen et al. Had done a study for 20 to 40 days on 57 women, and in this they had used a vaginal capsule containing 10 days to 8 to 10 days to 9 CFU Lactobacillus acidophilus or placebo for a period of 6 days. In this, we could see a 21% cure rate compared to 0% in the control group. The second study, Parent et al., who had done it in 1996, showed a considerable cure rate of 88% compared to 22% in the control group. The vaginal capsules were introduced 1 to 2 times daily, containing at least 10 days to 7 Lactobacillus acidophilus, and 0.03 milligram estradiol was also used for 6 days. So this this was done on 32 women for a period of 4 weeks. Another study also done by Anukam et al. In 2006 showed a 65% cure rate in patients who were given daily vaginal capsules containing 10 raised to 9 CFU of L. rhamnosus and 10 raised to 9 CFU L. reuteri, or twice a day 0.75 metronidazole gel for 5 days. And this was compared to 33% in the metronidazole only treated group. So this was done in 40 women over a period of 30 days. And next slide, please. So these are the recent studies in which we can see that Erickson et al. Has done it in 2005 or over a period of 2 menstrual periods in 187 women. Hello, Nishan, can you hear me?
Yes, ma'am. Now we can hear you.
Hello.
Yes. Yes, we can hear you, ma'am.
Yeah.
Hello. Okay.
Yeah, so I'll go ahead. Okay. So in this, there was a study in 2005 done on 187 women, and as defined by AMSEL's criteria, 56% cure rate was seen in the probiotic group, and 62% was seen in the control group. But as defined in by the Nugent's score, 55% cure rate was seen in the probiotic group, and 63% cure rate was seen in the control group. So in these, the lactobacilli used were Gasseri, KC, rhamnosus, fermentum, or placebo tampons were used for the control group. Now, the recent most study done by Bradshaw et al. In 2012, done over a period of 6 months on 268 women, showed a 72% cure rate when oral intake of 400 milligram metronidazole for a period of 7 days, followed by vaginal pessary containing Lactobacillus acidophilus of 10 days to 7 CFU, and 0.03 milligram of estradiol was given for 12 days as compared to 73% in the control group. So all in all, it definitely reiterates the fact that giving assisted treatment by a probiotic definitely improves the cure rate and also decreases the recurrence of the vulvovaginal candidiasis because of less adherence or less incidence of resistant bacteria which can start cultivating. So, and it also improves the natural defense mechanism. So definitely it is worthwhile giving it. Thank you.
Thank you so much, ma'am, for giving so much of knowledge on this topic for today. So let me check if we have any query in the comment sections. 1 minute. So, ma'am, I do have questions related to COVID. Is COVID vaccination contraindicated during this vaginal infection?
No, COVID vaccination is not contraindicated during any kind of infection. Now, the government of India has also recommended to give it during pregnancy for patients or couples who are even planning for a pregnancy. So, as such, no contraindications have been stated as of now. The reason being, even though we do not know the actual long-term benefits or long-term risk factors of the vaccine, as well as we are not well adept, about the COVID. But still, the benefit is definitely outweighing the risk because, as everybody is saying, the third wave is going to be much more widespread. So, from that scenario or from that perspective, it is recommended that we should be giving whatever small amount of immunity we can give to any person who is there, rather than keeping some contraindications or. So, if the person wants to take it, they are welcome to take it. Just like that.
And ma'am, I would like to know that how would you counsel menopausal women who are coming with this vaginal infection queries?
So basically, when a menopausal woman comes, there are two factors. One is an atrophic vaginitis, and the other could be that there is some amount of infection which is present. So both the factors have to be told that there are two separate things that we are dealing with, and so menopause, what it does is it decreases the estrogen progesterone levels very drastically, and it comes down to a baseline level, and because of that the thickness of the vagina decreases considerably over a period of years, and this is the main root cause that can be a welcome factor for any kind of infections. And then if they use any outside toilets, or maybe there is any problem with the hygiene factor or anything, then definitely also the other factor being that the vaginal opening becomes much more lax, so that is an important factor which is there. So that also any kind of the E. coli infections or anything, so this can start and cause an vaginal infection, and then they, because of the inflammation, the other opportunistic infections can also set in.
Okay. Then one more question is that can vaginal infection leads to pelvic pain or abdominal pain if not treated?
Yes, definitely. If it is not treated, then it can have entry via the cervix, through the uterine body, through the fallopian tubes into the interior of the abdomen or the interior of the pelvis, and this definitely can cause an entity called as pelvic inflammatory disease. So this is then the patient presents with severe pain in the lower abdomen. The patient can present with vaginal discharge, and also like just 2 minutes, sir. Yeah.
Yeah.
Yeah, so in pelvic inflammatory disease, the patient can present with too much of a pain. That is the main cause, and then it can be associated with vaginal infection, or it can give you, the patient will give you a history that the patient has been having vaginal discharge for a very long time, that she's neglected. So definitely, clinically also it gets clinched, and when we do vaginal checkup, that time there is fornical tenderness, that is there is pain when we press at both the fornix, so that clinches the clinical diagnosis. When we look at the sonography, there could be free fluid present in the pelvis, so that also reiterates the same thing.
And do you prefer to give probiotics to the patient who are coming with the recurrent vaginal infection queries?
Yes, what ideally, very frankly, even for the first episode of vaginal infection, I prefer to give probiotics in that too. So
Mhm.
definitely in a recurrent case, then the duration of therapy of the probiotics will be much more than whatever the ideal main therapy would be.
So, ma'am, I will take 1 minute of yours and would like to share one product from our company. Can I share, ma'am?
Yes, please go
Thank
ahead.
you, ma'am. So this is our product Totalis pre-probiotic capsules, and it contains different 7 specific Indian strain, and the total count is 10 billion CFU. So it will help from all the issues that are related to vaginal infection, that is H, white discharge and odor. So it is the dose is 1 capsule twice for 7 days for treating BV, and for recurrent BV, 1 capsule twice for 14 days. It will normalize the vaginal pH, and it will also act as a bacteriostatic activity, and it prevents the bacterial addition to vaginal infection. So this is our product Totalis. And thank you so much for giving all the answers for the questions and updating the knowledge to our participants also. And I also thank the participant to join for today's session. And I also thank our Shield colleagues who made this webinar possible with you, ma'am. And we would like to have more webinars with you in the future, ma'am.
Yeah, definitely. Thank you so much for calling me. It was a pleasure being here.
Thank you, ma'am.
Thank you.
So we can wind up the session now. Thank you. Bye.
Yeah.